Hey people, Amora here, and you are listening to His Health, the podcast dedicated to all things love, health, and wellness for Black gay men. As you know, our show allows providers to share really everything, their strengths, their weaknesses, all that they've learned along the way in their journey to providing uplifting care for LGBT communities of color, especially Black gay men. We are back with part 2 of our convo with David Malebranche, a board-certified internal medicine physician, researcher, and public health activist with expertise in HIV, sexually transmitted infections, and LGBT health. Dr. David Malebranche currently resides in Marietta, Georgia, and works in correctional health. And you can check out part 1 of this podcast on our His Health podcast feed. So during today's discussion, we discuss with David his advice to providers in approaching the topic of sex, the challenges of providing care in different environments, David's prominent article featured on NBC where he highlights a really amazing conversation at the Barbershop about sexual identity, and also understanding the level of acceptance that loved ones will have with one's sexual identity. David also helms the Whole Health CME CNE training on the His Health website. All you got to do to find that is just head to hishealth.org, click on the Continue Education tab, and you'll find 4 hours of free continuing medical education coursework to help you offer the best care possible. All right, you guys, let's get into it.
We've talked about possibly providers who would feel like, I think these are great suggestions. I don't have a lot of time. Awesome strategies, not necessarily in my field. To your point around your sentiment, and correct me if I got this incorrectly, that some folks are going to get it and some folks don't. Thoughts for those who the strategies are common sense, they totally seem logical. Providers are human beings first. If we're really talking about humanizing medical care, we start with the fact that providers are people first and come with their own misgivings and challenges and personal beliefs, etc. What are some thoughts around how to help providers who are just legit uncomfortable talking about sex for a number of reasons? Maybe you got out of your residency and you're 29, 30, and you just really feel uncomfortable asking some older Black gay man who looks like your daddy about, you know what I mean? Just like, and that is a thing that we got from a focus group with Howard University med students. And we were like, on a scale of 1 to 10, what's your comfort talking about this? Well, if they look like my mama or my daddy, I'm 28. I feel fucking awkward. You're an older doctor. You know what time it is. What's your guidance to that young Howard University med student?
about being honest with stuff?
Yeah. And getting comfortable and dealing with their own discomfort and miscomfort.
Yeah, I think it kind of reflects from us, though. I put the burden on the provider, and this is just the way I operate, because I think we make that visit comfortable or not comfortable. And so there's transference that goes on in clinical situations all the time. Like somebody looks like my daddy, somebody looks like my mommy, somebody looks like my son or daughter or my uncle or brother or sister. And you're going to transfer those kind of feelings with that, but you can shut that down with kind of how you operate within this space. So you won't be that kind of father figure if you're sitting, if you make the space an open one for conversation. So, they may be embarrassed at the beginning, but you can say things like, I ask these questions of all my patients. I just need to kind of know so I can, provide you the best recommendations for your health, or I can recommend to you the best vaccines or the best tests to get. So I want you to be able to feel comfortable with me doing that. So I haven't had any problems personally with people if I'm a little bit older feeling uncomfortable. And I think that's because my energy, I'm a little bit more youthful with my energy. Like I play around, I curse. I'm kind of non-traditional. I do everything like my mentors told me not to do. I do that with my patients, and it's actually worked, I think, where people feel comfortable with me. And of course, I'm going to rein that in a little bit. If someone's a little bit older, more reserved, I think it's a matter of kind of feeling out who your patient is. And so there may be a younger patient who's really not comfortable talking about their sexuality. And then there may be ones that are really, really brash and really want to talk about it and really upfront about it all the time. And I think as providers, our job is to kind of feel that out and also make it open to them. And so to say, like, I can tell you that I've had patients before that I've said, hey, so I want to talk a little bit about, I know this is our first visit. You're just getting to know me. Mm-hmm. But I was going to ask some questions about your sexual history, behaviors and stuff like that. And if I can see that they look comfortable, I'll be like, are you comfortable with that? And sometimes patients will say, can we wait till the next visit? And I'll be like, sure. And I think that permission, so that it doesn't feel like it's something coerced or something that they have to do at that moment. Again, it leaves some of the power in the patient's hands, and then they can come back and do that. And invariably, in my experience, my patients have come back and said, well, okay, yeah, so I'm seeing you for the second time. Are you ready to talk about this stuff? They'll be like, yeah, I think I can, I'm feeling you out a little bit, so I think I can talk to you. I was like, okay, what do you want to talk about? And then they kind of go from there. But I think there's no right patient template again. So it's up to us to kind of figure that out and just make the space a very safe one. So people, if they're comfortable, they can feel comfortable saying it. And I think that part of it transcends like gender, sexual orientation, race, and age. If you can make that environment comfortable, some people are skilled at it, some people aren't. Mm-hmm. If you can make that environment comfortable, I know people who are, in their 20s and had an old doctor in their 60s, and they were like, my doctor is so cool, man. I could talk to him or her about anything, and blah, 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 blah. And they feel comfortable. And, that could be someone that could be their grandmother, or could be their father, or, whatever. So it doesn't so much matter the age of the person or the gender, the sexual orientation. I remember when we did the research project on, Black gay men years ago, and we asked them if they had preferences, and most of the guys said, I just want you to be good. That'll make me comfortable. Just be good and just treat me like a human being. That's what they meant. It wasn't about being a certain way. And if you're good, if your energy is kind of positive going into it, you're not acting judgmental, or you're going to be paternalistic or finger waving or anything like that, people will sense that and they'll open up. It may not be that very first visit. It may be a second visit or a third visit later, but it'll happen. But I think the provider sets the tone. It's not up for the patient to come in and set the tone for that. The provider has to set the welcoming environment. And if we're not doing that from jump, particularly with regarding to sexual health, for Black same gender loving men, we're really missing the boat.
You've been going into depth and giving some really awesome common sense things that folks can do on their one-on-one interaction with patients. But, you especially, between the two of us, are well aware of all of the other issues that are happening outside of that patient visit, both in the clinical space, and I think also just within systems of care in our society, with wherever a provider may be practicing, which can be sort of disempowering sometimes if you just feel like there's so many other things that I cannot manage or handle. I feel that I feel like teachers must feel that way as well. Like, I'm expected to be a parent, counselor, provide for all this stuff, and I can't really do it. I would love to hear a little bit about your experience with where you are, and you just mentioned it before. You were in practicing in Pennsylvania at UPenn Student Health Center, now in Marietta, Georgia, a bit of a different setting. What are some of the sort of institutional issues or societal issues or challenges that your patients are facing where you are now, in the state that you're at now, in the city that you're at now? Like, what's the landscape like for care?
Yeah, I mean, I think it depends, being at an Ivy League institution where there was a student health center and the students were expected to have some kind of insurance plan. They had an insurance plan when they came in. It's a completely different context. They were very flexible. The schedules were flexible. So if something came in, it wasn't just around sexual health, but if there was a patient that came in and had, suicidality or was depressed and needed a little more time, we could speak to the nurses and say, hey, or whoever was scheduling or kind of taking care of everything, say, hey, I got a student, I'm going to have to take a little bit more time with him or her. Can you kind of give me a little bit more time, or is there another provider that can see my next patient? And they would sometimes shuffle those around and do wonderful work with that. And that was, attesting to the teamwork of everyone that worked there, both, the nurses, the providers, the MAs that were there, everybody. And so that made it flexible, and that systems approach made it nice so that if something did come up that you needed to take a little bit more time, you could. By the same token, they knew that if they had somebody coming in to see me for a pre-exposure prophylaxis discussion, they would give me a half hour automatically, because they realized that this would be an in-depth discussion about sex, sexual behavior, medications, side effects, what to expect. And it typically did take about a half hour, in addition to like the testing and everything. So they would make some concessions with that. And I think from that systems approach, when you had insurance and you had everything kind of stable, that was great. Like working at a correctional facility now, it's a little bit different just because the flexibility is still there. So there's not like a time frame with patient appointments. You can see them and take as little time or as much time as you want. But I think there's such a large demand in an institution where you have low income, often homeless, dealing with a lot of mental health as well as substance abuse issues and chronic medical issues on top of that. To try to get that into a visit, to try to provide the care for that, to try to make sure that people are on the best medications they can be, all within kind of a context of the public jail or clinic doesn't have resources just at their disposal to do everything. So you have to think within paradigms of, what is feasible, what can I do, what is possible, what is not possible, and when to kind of push the envelope a little bit and say, well, okay, I know this is going to cost something and I know we're going to have to suck this up, but this patient really needs this, versus something where it's like, well, they may not need this right now, or we can wait a little while on this and, treat them with this medication or do this, that, and the other. And so it's a completely different context with regards to that. But I think your point about systems, we have talked a lot about the one-on-one, patient and provider encounter, but there's so many systems that you can put in play either in institutions or in general. Like some of the things that when you mentioned it were popping off in my mind, like I think just for clinics, like instead of saying, well, you're going to see, instead of it being a numbers-based thing, you're going to see 15 patients in a half day. Like that's unrealistic because not all 15 patients are going to be the same, and they're not all cookie cutters. So to say, well, okay, if this patient came in with this problem, we need to give them 20 minutes. If this patient just comes in with the sniffles or cold symptoms, you give them 5 or 10. And if this patient is coming in for, STI screening or, pregnancy testing or wanting to talk about, their 8 medical problems, then you give them a half hour. Like, I think those systems up front that don't just dump everything in the provider's lap and say, okay, you sort it out, is helpful up front to kind of make sure the time is allotted that's going to be appropriate with each of these people. Of course, you can't always predict that someone comes in for one thing and then they've got 3 other things going on. You can't always predict that, but you can put those things into play to kind of help that out. So I think from a systems perspective in institutions like clinics, and different kind of places that provide services, those are helpful. But I think even bigger on kind of a cultural landscape, retraining nurse practitioners, physician assistants, medical doctors, it has to start in medical school. So some of this training about taking a good sexual history, getting comfortable talking about sexual behavior has to happen in the first couple years of medical school, continue on through their clinical years, and then be part of residency curriculums. If it's not included in that part, they're going to miss out. And then students and residents are going to be left to their own devices to say, well, I wasn't really comfortable with that anyway, so I'm just not going to focus on it. Because that's easy to do. If you don't have to challenge yourself to, do something new or do something different or step out of your comfort zone, you're not going to. And so I think unless we put it in the systems to say this is going to be integrated and part of it. And for instance, when we have in medical school what's called problem-based learning, where you give a case to a group of second-year medical students or first-year medical students and say, well, okay, I'm going to give you this case, and it's going to intersect all these different things from anatomy to physiology to, social issues, to behavioral health, and then maybe neurology and cardiology. So you integrate all this stuff into a case to show them, like in the real world, this is how it comes across. That is where you put some of your sexual diversity training in. So instead of all the patients being, these kind of static, black male, 37, white female, 54, you put something in like, 45-year-old transgender woman who is on hormones but doesn't want to get surgery is coming in complaining that her kidneys are bothering her, right? So it's not, and you don't just do it to do lip service to say, okay, we're going to have a transgender patient because we're going to talk about transgender issue today. You put it as, this is what you're going to see every day. So your transgender student or transgender patient that comes in is not necessarily always going to want to talk about her hormones or about her surgery or about her gender identity. She may come in and just look at you and say, my chest hurts, figure this out, or I have a cold. or, you know, my butt itches, or I have a pain in my thigh. Figure it out. Or I'm short of breath every once in a while. What are you going to do about that? You know what I mean? So people can realize that it's part of the norm. So it's not like this exotic, oh my God, it's a transgender woman, so now we have to talk about transgender issues. That should be part of your consideration, but it should be part of the whole picture consideration. Because I've had transgender patients come in and say, I went to see this other doctor and all they wanted to do was talk about my hormones. And I had a cold and bronchitis and I was wondering what they were going to do with that. And they seemed really fascinated with with the transgender part of it. And I was like, I'm laughing now, but that's kind of traumatic too, because for someone who's transgender, to go in and every time, like, they can't just come in with a routine complaint. Like, someone who's not comfortable or doesn't know about it is going to always, by default, go to want to talk about these things because they're fascinated or not sure what to do or uncomfortable, instead of just saying, well, this is a human being, and are you good on your hormones? You taking all your hormones? Okay, good. Now let's focus on this bronchitis.
Right.
You can check in and acknowledge that part of it, and acknowledge who they are respectfully and in a very, comforting and inviting manner, but still focus on, and again, going back to what the patient's priority is. If she comes in, she knows she's been taking hormones for years. She knows what she's doing. Mm-hmm. She's coming in for a cough, so deal with that. So that's the way I kind of look at it.
Let's talk a little bit about your book. The little thing you just did on the side, You just pumped it out real quick amongst the many other things. You wrote a really quite a wonderful memoir, Standing on His Shoulders. Do I have it correct?
Mm-hmm. Standing on His Shoulders.
Yes. In which you talk about sort of the intricacies of your relationship with your father. And earlier this year, you had an essay published on NBCnews.com in which you discussed an experience you had at a barbershop discussing gender identity and sexual orientation. And I was wondering if you could share with the audience a little bit about that experience.
The barbershop experience?
Yes.
Yeah, it was, I just moved down to Georgia and I'm living in Marietta, and I didn't have any recommendations for a good barber. And I went to one and I wasn't really too impressed. So I started just driving around randomly and see what I could find. I just stumbled across a barbershop. And got in the chair and started talking, and people were just clowning and talking about stuff, and we got on the talking of I think it was Tamir Rice had been going on, where was it, in Cleveland or Cincinnati, wherever that happened. Mm-hmm. And we were talking about police shooting young black boys, and everybody was kind of chiming in. We were having this really lively discussion about it, and then someone out of the blue just came out and talked about Jaden Smith, Will Smith's son. Mm-hmm. And how he had gotten some, contract with Louis Vuitton for girls' clothing or something. And they said, yeah, I can't believe that shit. And and then it went from Jaden Smith to, Caitlyn Jenner, and how, he still has a penis. So he's still a man as far as I'm concerned. Mm-hmm. And, when it first happened, I thought I was just going to kind of let it go and just let me get my hair cut. It's my first time here, whatever. And then they just kept on, they just kept, I was just like, let me just get the fuck out of here. And they were like, well, it's disgusting and da-da-da-da-da, and I can't believe this and that. And they were just, and I was like, okay, look, like, I really got to give trans 101 here. So I just started speaking up and just started saying stuff about, how people are and, what people are and, the difference between or the similarities between white privilege and heterosexual privilege, and different gender identity issues, and how gender identity is different from being gay. Like, they were just going back and forth within it. So there was just a lot of conversation to be had, and I could tell they weren't really comfortable with it, but they were curious. And then, of course, curious about why I'm speaking up about it. And so, I just, kind of disclosed myself, and I was like, I like men, and I've known this for a long time. I said, nobody's looking at any kind of concessions or wanting any special treatment. I mean, this is just the way it is. But they were like, well, they want us to do everything for them, and they want us to do this, and they want all the special treatment. And I said, do you understand how the world caters towards straight people? I mean, do you understand? Like, you can kiss in public, and you don't have to worry about getting shot. You can put a picture of your wife on your desk at work, and you can talk about who you conquered, the night before at the club, and everyone's going to affirm you. I say, it's not the same way with people who, are gay. And I don't think they had really thought about that, because they were like, I just don't want them to shove it down our throats. I don't want them to shove their lifestyle down our throats. I was like, don't you think straight people shove their lives down everyone else's throat? Isn't that what happens every time we watch The Bachelor, or every time we watch some of these other TV shows about straight people hooking up, or every time we watch a soap opera? Like, you're shoving your lifestyle down my throat. Or, I don't want to hear about your kids. I don't want to hear about your vacation with your wife. I don't want to hear about all that. So don't you think you're shoving your life down my throat? So why don't they get to talk about their lives? Why don't trans and bisexual and gay people get to talk about our lives? Like, that doesn't make sense. And they really hadn't thought about it. So some people just kind of turned off. There were some people that were really silent, and then there were others that were asking questions. And then a couple of the brothers at the end, when they finished my haircut, he was like, man, it's a good conversation, man. I'm glad, we had that conversation. I knew they kind of understood, and whether they were playing service or not, I could kind of tell it got them thinking a little bit. So, but I wrote the story because I almost feel it's a universal experience. It's almost like a rite of passage that every Black same gender loving man has, is that moment when you're in the barbershop and someone starts talking shit about, gay people being perverted or a sin or it's wrong or this, that, and the other. And you have that choice because you really haven't talked about that kind of stuff in a barbershop before. And you can either, just be silent and let it do what it do, or you can speak up. And I think we've all taken different roads at different times. There have been times when people have said a couple things and I've just said, it's not that important for me to speak up right now. It's not that I'm not going to wage this battle right now. It's not the time. So I've just stayed silent at that moment. But other times I've been like, okay, I'm going to shut this down now because I can't deal with this no more.
I'm curious about your decision-making process around that. And I love that you brought this up. Queer Black women go through the same shit. I remember being 23, working at the National Institutes of Health in the office of the director in Rockville, Maryland, and I reported to two amazing Black cis Christian women. And I remember us going out to lunch one day, and one of my bosses was talking about when she was a teenager, her older sister. She was like, one day my older sister, let's call her Pam, started dating Julie from up the street, and it was just nasty and just disgusting. And my mom and I found out, we just laid into that ass. And I'm 23 and I'm like, okay, I'm temping here. I really need a job, but I'm super clear. If my girlfriend comes up here in all her glory, that's a mess. Right. And you're making all these micro decisions in the moment and playing along like, oh my gosh, for real? Word? No way. And in your mind, you're like, well, damn. Am I going to be, if I were to disclose? Right. But I also know about the power I have in that in a lot of ways, I'm able to pass. I'm so curious to sort of hear about your perspective on that. Like, how do you navigate when to disclose, when not to? Like, for me, it gets fucking weary. I'm older now, so I'm more comfortable, but being younger, it was hard.
Right. Yeah. And I think that's the key point, is that as you come along in time, and different people, get comfortable with themselves at different points of time. So I think it's just a matter of where you are, as far as what you say or what you decide to do. And I think, for some people, it depends. Like, some people can clock me pretty easily. Some people will think I'm straight. Some girls will still hit on me and assume that I'm married. In fact, one of the female inmates today was like, are you married? Because, I need to holler at you when I'm out of here. And I was like, okay. And I'm just, and I'm not going to tell her, girl, you barking up the wrong tree. But, it's just what it is. But I think it's just one of those things where you pick out. But I think one of the discussions that came out of that article, which I really appreciated, is the privilege that I had by, and who I am is not like a performance in any way, shape, or form. Like, I'm not faking who I am, but I understand that the performance is more of a traditional kind of masculine performance. And so for someone who has more traditionally or accepted like feminine traits, they may not feel as empowered to make that discussion or do that at that period of time, or that discussion may not even happen because the group that they're in already perceives them as gay. Right. And so they're not even gonna
issue to even talk further about that.
Yeah. They're not even gonna bring up that topic because they're looking around the room and they say, oh, we got somebody who's gay in there. I'm not even gonna say it. Others will say it just because they notice it's someone
Yeah.
that they think is gays, and
they
they
wanna
want to
say
make that
something.
person uncomfortable.
Mhm.
Yeah, they want to see what's going on. And so I think it becomes an interesting dynamic. What do you do? I think it depends on who you are. It depends on how old and mature you are, how comfortable you are with yourself. I think it depends on your masculine and feminine energy and where you are at the time. So I think there's a lot of things that come into play. You can't just say to everybody, it's like telling everybody to come out of the closet, whatever that means.
Mhm.
It's not that easy for everybody, and it's a journey, and it's fluid. So you can't always just tell people, well, when you're in that space, you just need to speak up. It's like, well, if I'm in a space in a certain city or a certain area and I could get shot, I may decide not to speak up at that moment. I may not decide that that's the battle. Yeah, I may not decide that that's the battle for me. I may try to live to wage a bigger war on a larger scale at a different time. But I think that's a very individual decision. I don't think there's a right way to handle it one way or the other. So there would be no judgment or kind of second guessing or Monday morning quarterbacking where I'll be like, you needed to do blah, 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 blah. Like, why didn't you just speak up? You such a, wimp, and you're soft and this, that, and the other. It's like, no, that's not the case here. It's just, you have to choose your battles sometimes, and that's just the way it is.
And what was your experience like? You are very open about your relationship with your father and the journey around full acceptance of who you are. But what was that like? Sort of sharing that with your father, or how did those discussions come about?
Yeah, it was just tough at the beginning.
Mm-hmm.
My mother basically told him, because he had suspicions based on the fact that I had pierced my ears. So he was asking her questions because he was scared to ask me because he knew the answer to the question.
Mm-hmm.
And so we ended up having a conversation. Of course, it doesn't go well. Like, how would you expect a conversation about being same gender loving to go with a traditional old school Haitian West Indian father? It's not going to go well. So it's not always going to go well. So, but I think over time he kind of warmed up to the idea, and he realized that I didn't change. Like, it was just who I was. And so he had to come to a point in his journey where he realized that some of the things that he had planned for me or had expected of me in the life he wanted for me was not necessarily the life I was going to have. And he had to let go of that. And I think, and I tell people this,
What were some of those things?
Married, picket fence, kids, moved to upstate New York, become a surgeon in his practice and take over his practice for him. I mean, he had concrete dreams of what he wanted me to do, just follow in his footsteps, like verbatim.
Mm-hmm.
And he had to let go of all those because, you have to realize with your kids, they're going to be different people and they're going to be beasts of their own nature. So you kind of have to let them go and let them do their thing. And so he had to come to a part of that journey. And I think the acceptance about my sexual orientation was a part of that. I don't think that parents always become 100% comfortable. Yeah. And I think for my parents, it wasn't something where, I don't come home and they're like, how, do you have a boyfriend? What's going on? And Dad's not going to say, tell me about the man you're dating. So like, he doesn't do that. But, the fact of the matter is that he may never do that. And I tell people all the time, because I think this is so, so important. And I remember telling, and it's slightly apples and oranges, but the parallels are there. I remember telling one of my trans men at my practice in Pennsylvania, who was just beginning his transition with hormones, like just about to start and getting comfortable with, telling his folks and everything. And I remember he got really, really upset because his mother referred to him with the female pronoun and called him she at one point. And he just got really, really upset. And I said, and someone else had told me this, so I just passed it on to him. I said, look, you realize, I said, how long did it take you to get to this point in your journey? And he was like upper 20s, maybe early 30s. He said, a long time. I said, then why are you expecting your mother to get on board with it within a few days or weeks? She's going to have trouble. And the point is that sometimes we have to forgive our parents or our loved ones who may not be able to completely be on board with us. That's their limitation. And it's not so much that, they have to forgive us for being, same gender loving or being transgender or gender queer or gender nonconforming. They don't have to forgive us for being that. The more important is us forgiving them for not having the capacity to accept every aspect of who we are. They may not be able to do it. And it's our hopes that they would and just come to love us for who we are. But you have to realize that that may be a fairy tale. And so you may not always have that full acceptance, and you have to be okay with that. And you have to forgive them for that, because they're human beings too. So I think that's kind of one of the big points I learned from my dad, and one of the big things I try to pass on to other people that are, struggling with issues of disclosure and sexual orientation and gender identity with parents and loved ones. It's not going to be a perfect road all the time, and we have to be forgiving. I don't think we think of it that way, because we're always looking at it from like, well, you just need to accept me for who I am, and you need to call me by my new my transition gender pronoun, and you need to do this and you need to do that. And it's like, well, actually they don't. And you have to kind of find it in your heart to forgive them for being human and not being able to accept things.
Yeah.
They may come around, they may not. And that's what it is.
Yeah. Or, in my case, like, stop calling my girlfriend my little friend.
How's your roommate doing, Amoro? How's your roommate?
How's
right.
I mean, for me, it wasn't even a matter of forgiveness. I just like tilted the frame of what like the view of my mom, or what like my mom loving me and my life and the way that I'm living my life, what it looked like. And I think once I tilted, I'm like, oh God, this is really sufficient. My mom was like 70 something, grew up in, post British colonial Nigeria in like the 40s. The fact that she was able to accept me and my girlfriend and have us over to the house, always ask about her. She might not ever call her my girlfriend, my partner, my fiance. That may never come out of her mouth, but her arc has been tremendous. And I think just sort of just like really looking at how far she's come and accepting and starting to view that as like an expression of love and acceptance has really helped me to feel full.
That's huge. That's absolutely huge.
Yeah. And it sort of definitely took a long time for me to not be like, well, if it doesn't look like this, if it doesn't look like the ABC after school special, then it ain't real. But this is what you're going to get in 2016 with your Ishan mama. Like, this is where you're at.
Right. I remember my mother, there were certain times where she would ask and she would stumble over her words. And like, so how is, I said, and so one time I just let her off the hook. I said, Mom, you don't have to ask about him. I know you're not comfortable yet. It's okay. Like, I won't get angry at you if you're not comfortable with it. And she just looked at me. She said, okay. And I mean, I was just giving her permission to like, just not be uncomfortable with it. Cause I'd rather her not say anything than try to fumble through it because she's really forcing it. And that makes it really an awkward moment. So I was just like, let's not do that.
Yeah, my mom was like, I ain't stubborn, girl. How's your friend? Okay, fine. You're lucky that I asked. And there's definitely some like education that I try to throw in a way in the most respectful way, right? Because no matter how old we get, we still somebody's, child, and it's still your mama, etc. But I think a little bit of that education piece too can come into play when you're working with your doctor or provider who just is like not comfortable or not knowledgeable in terms of like how same gender loving folks interact or are intimate, etc. I think we just to kind of tie the two, what are some strategies that providers can use to empathize with Black gay men? Some of the things that we're talking about definitely extend outside of, again, the clinical space. But like, if someone is listening to this and can say, okay, I get the complexities of what you're dealing with in society, what you're dealing with the intersectionality, what the challenges you have to deal with in terms of comfort and disclosure with family and friends. How can they take all of this and affect or engage better when they're working with their patients, having this understanding of the whole patient?
Yeah, I think just asking the question, and sometimes just not being afraid. And you can start off even with like just medical spaces, because sometimes I'll just ask a general question if someone comes in and they seem really skittish about either telling information to me or just seem distrustful, and I'll be like, well, tell me what your thoughts are about, or what your experience has been like with medical providers in the past, or tell me how you feel about taking pills.
Yeah.
Like, And then if I get a sense of it, if I can kind of sense that, I'll ask the open-ended question, and then they'll be like, I hate taking pills, or I've had really shitty experiences with doctors in the past. And I'll be like, okay, well, let's talk about that. And you know, I think sometimes for providers, they don't want to talk about racism. Nobody wants to talk about racism.
It's a lot to tackle. Like, it's not my place. Yeah. You don't want to.
Yeah, except for Black people. Like, we tend to want to talk about racism all the time, because we'll be like, that's racist, and then we move on. But a majority of the population really would not want to talk about it because it's uncomfortable. And the medical setting is just a microcosm of that. But I would say kind of tackle it head on. And, you know, have you ever had any experiences where, you know, a provider, you felt like you were judged because of, you know, your race, or because you were Black, or because, you know, your provider was homophobic? Did you have any experiences like that really turned you off to it? And I imagine, like, asking the question in that directive of fashion for a lot of patients would be like, oh yeah, I did, and I didn't like it. And so again, you can kind of give them power and agency to be open about that, tell you how they feel, and then you can kind of move on. And I do think that's part of the social history. So you know, while we're talking about, you know, the history of present illness, you know, the chief complaint, the past medical history, I think social history is where it's not just, you know, tobacco, alcohol, or drugs, but it's talking about, well, tell me a little bit about you. Where are you from? And that may only take like a minute or so, like, to kind of unpack that and get through some of that detail about what's going on, even if it's just initial, like, it lets the patient know that, you know, you're interested in them more than just a number. It's kind of, well, who are you as a person? Where do you work? Are you in school? You know, do you have somebody in your life right now? And not making assumptions. I think when I think about providers and what they can do, it's really the simple things about not making assumptions.
Yeah.
Like, not making assumptions that they're straight, not making assumptions that they're this. Tell me, are you romantically involved? Are you with anybody right now? And then let them kind of open it up and go from there. I think that sometimes not making assumptions is good. And you may trip up. And that's the thing. I think some people are afraid as doctors and as medical providers, nurse practitioners, PAs, like, we'll mess up and we'll make a mistake. And you can't be afraid of making a mistake, because if you're not, you won't learn. You could trip up with the gender pronoun for some of your trans patients, and you may say he or she, and they'll correct you.
Yeah.
Or they'll throw you a side eye and look at, like, wait, you know, that's not my gender pronoun, you know, and then you kind of create, oh my God, I'm sorry. And then you kind of get it right. But if you get in the habit of doing what you need to do and being more respectful of who your patients are without making the assumptions, the relationship will go much more smoothly. And if you take that time up front, it's less time you have to use later on.
Yeah.
You can just focus. You can just focus on the relationship. So, how you doing? How your kids? How's your partner? How's this? Da, da, da. Okay, let's talk about your medical stuff, and then, you know, you go on from there. But if you don't put in the work at the beginning, but again, these systems need to allow providers to have the time to do that. So, give us 30 minutes or 45 minutes to get our patients on that first visit. And then after that, once we set that established visit and we know each other decently, then we can move forward to, you know, talking about the small thing. Oh, you're coming in for chest pain today. Tell me what's going on. Is everything okay? Then you can, you know, do a quick visit because you already know who the person is.
Speaking of updates to practices and systems of care, looking forward to the future, what is one idea or practice that, you know, you've been thinking through that you think in the future, this will be so critical and so helpful in improving care engagement, both for HIV and sexual and holistic health with in working with patients?
On a systems level?
Yeah.
I think a couple things. I think the traditional model of healthcare right now is going to phase out at some point. I do think the idea of kiosks and telemedicine is going to flourish over time. But I also think at the same moment, I think kind of retroactively, or almost like just throwback to the days of like visiting people, like doing home visits, I think is going to have a resurgence as well. And I think would be better for care on some levels.
Yeah, especially folks who are sort of out of care and where home is super duper transient.
Right. And may not have access to transportation or may have some other challenging issues. You know, the fact that there may be a component to a medical practice or a system or a provider that they have the ability to kind of take a van and go out maybe draw their blood and just do a quick exam, talk to them for a little bit, meet them at their place. And then you can actually, I think it benefits the provider too, because the provider can see where they live every day and who this person is. It's not just the person that shows up late, on purpose, just to piss you off and throw a monkey wrench in your day when they come in late for their visit. They actually have a lot of competing things that are going on that cause them to be late or cause some problems with adherence. And for you to see that will be tremendously beneficial for you as a provider to kind of understand your patients a little bit better and have a much better relationship. So I think those are some things that I think are going to happen in the future. I think already some of the things with, the medications being once a day to something that's going to be injectable every 3 months is going to help with adherence and, follow-ups and those kind of things. So, I think the technology is there. I think the trick with technology is that you can get technology, but you have to maintain some kind of human element to medicine. And if you just go with the technology and you turn it into completely non-human interaction, it's going to be worse for Black people just overall. I just think the racial disparities will get worse and worse. So something has to change on both those levels. The technology without the social advancement is going to be nothing.
You have to go hand in hand. What's next for you in your work with this patient community with Black gay men?
I've been batting around a lot of ideas, but I really like the idea of, after doing those YouTube videos for Ask the HIV Doc, I do think doing videos like that, short videos like that, on a broad variety of health topics, not just sexual health, not just about HIV, not just about PrEP, but about different topics like allergies, asthma, diabetes, high blood pressure, vaccinations, prostate cancer, I think will be helpful and make them unapologetically and directly geared for Black gay men. Yeah. People may check them in and get the information for it, but I think the answer to this problem is that everyone seems to want to talk very specifically about Black gay men when it comes to splashing negative and pathological statistics. 1 out of every 2 Black gay men will get HIV in their lifetime. And then if you notice when the solutions are proposed, it gets diluted down to men of color.
It's everyone.
MSM of color.
Yeah.
And then when you start to say, well, we need to do Black gay men, they're like, well, why are you being so specific?
Right. What about?
Weren't you being really specific? Yeah. Weren't you being specific when you were splashing all the negative HIV statistics? So if you have that specific of a problem, why would you not propose specific solutions? And I think that's been a huge problem in the fight with HIV and Black gay men, is that everyone wants to tell us about how pathological we are specifically. And then when it comes to the programs that can help save us, it all of a sudden becomes Black and Latino, or men of color, or just MSM in general, or Black men in general. And it's like, no, if you're going to pathologize us specifically, then let's talk about the solution specifically. And I think we have the power to make that unapologetic and propose those solutions. And people can get on board if they want to. I don't care if you're not Black and gay and you want to access videos or information that we have that may be pertinent to you, even though you may be white or not an MSM or not gender non-conforming. I mean, it doesn't matter. Some of the information may be relevant to you, but we'll be very, very clear that some of these initiatives have to be targeted towards Black gay men specifically. So that's where I want my work to go. I've already left out of academia. I've already kind of done a lot more clinical stuff. So I think for me, the stuff that makes me most happy is being able to see patients and then being able to pick and choose the public health stuff that I want to do that means the most to me. So
yeah, and I have to tell you that with what you're doing with the Ask the Doctor and with the His Health CMEs, yes, shamelessly plugging, I really love the fact that you're standing behind resources that are widely and readily available to the public, free of cost, really minimal barriers to get to. I'm really of the mindset of it's not worth it if, number one, it's not easy to digest and it's not easy to access. It's like, then you didn't do it,
Right.
There's no
right. And I think that's the main difference. And I mean, this is not anything to knock academia.
Sure.
But I think with academia, a lot of times we publish papers, we get promoted, we speak at conferences, and it's to a select audience. And I can tell you just through my own personal experience, people don't know a lot of the articles that I've written, but they do know the letter to Oprah I wrote. They know the open letter to same gender loving Black men that I wrote. They know me from the YouTube series. They'll know me from the His Health series. They'll know these things because they're more widely accessible. And you're right, they're more easily digestible. So to me, if I can do something that's going to make a broader impact, specifically using social media and other forms of media where a lot of erroneous information is passed on, if we can be that voice of reason, and that voice of truth, and that voice of, being upfront and standing in our own truth, then I want to be that. I want to be that.
Totally. David, thanks for joining. I always love talking to you, brother. This is a great conversation.
Likewise.
Yes, everyone, you are listening to His Health. This is the podcast dedicated to all things health, love, and wellness for Black gay men. We want to thank Dr. David Malebranche for joining us again. Please follow him on all the social medias, especially Twitter at DMALEBRANCHE. I have a feeling I've been mispronouncing your name. I feel like there's a correct way to say it. There's a Malebranche. I'm doing too much.
You did it perfectly. I mean, there's a French thing. So if you want to say it correctly, you say Malebranche.
Malebranche. Yes.
Oui.
That's what it is. I've been missing that. I've been meaning to ask you that. So follow D Malebranche on Twitter. Get into it and check his amazing CME series out on hishealth.org coming August 2016. David, thank you again. Enjoy your evening, and we'll be in touch.
Thanks, Amora.
Take care. Bye.